I will say, as elementary school kids that got let out about 10 minutes before the peak part, it was very exciting. Lots of science lessons and lots of applicability. So I learned about rotations and things I didn't know. So it's very helpful. I'm happy to introduce Dr. Lisa Prosser. You probably need no introduction, but I'm going to go ahead and do it anyways. She's the Marilyn Fisher Blanche Research Professor of Pediatrics and Professor of Health Management and Policy here at U of M. She also serves as the Associate Vice President for Research of Health Sciences in the Office for Vice President for Research at U of M. Is that the correct title? Okay, great. Her research focuses on measuring the value of childhood interventions using methods of decision sciences and economics. So thank you for coming to talk with us today about cost effectiveness.
Great, thanks so much, Sarah. And I appreciate the hardcore CHEAR attendees here for an introduction to cost effectiveness analysis. This will be just exciting as the eclipse yesterday. So as I go forward, those of you that know me, I do not love to lecture. Feel free to jump in at any time with questions, and I'll kind of pause along the way as well. So I'm excited to share today a brief background on cost effectiveness analysis. And again, trying to focus from a user or consumer perspective, understanding that most of you will not be engaging directly in the in a cost effectiveness analysis. Although if you are, that would be very exciting. And I'm always happy to talk more about CEA. But I'll start with a brief background and focusing on definitions, as well as some common misconceptions around the use of the term cost effectiveness. And then for the second half of the presentation, I'll go through a worked example, which is presenting some of the work that we've been doing recently with the ACIP evaluating their COVID-19 booster vaccination program. And just a quick preview, the booster vaccination analysis, I am hesitant to say within this crowd does not yet include pediatric subgroups. And I'll talk about why not when we get to that part of the analysis. It will be included for our June presentation to the ACIP. So just starting with a little bit of background on cost effectiveness analysis. So first, cost effective does not equal cost saving. This is something that we still kind of hear kind of anecdotally, but what we're talking about when we're talking about cost effectiveness is how much value are we getting from an additional investment in healthcare, a new health intervention, vaccination program, any type of, anything from cancer treatment to treating heart disease to anything in pediatrics. We're really thinking about kind of what is the return on investment. And so just kind of thinking about other things that we invest in, when we buy a house, we don't expect it to be cost saving. It's providing shelter to us. Similarly, when we invest in health interventions, we don't expect them to be cost saving. We expect them to be providing additional help to us. We typically measure that in quality adjusted life years, and I'll talk about those a little bit later. So what is cost effectiveness analysis? It is one type of economic evaluation that compares the relative costs and relative outcomes of two or more alternatives. And the goal is to provide information to decision makers that can assist with resource allocation and policy decisions. And when we get to the worked example, I'll talk a little bit more about the application of CEA. There's always a question that comes up, like, can we potentially use CEA at the individual level? And that is actually very difficult to do. And the standard approach for cost effectiveness analysis is really for population level decisions. So when we're thinking about kind of vaccination programs, that cover the whole country, or other prevention programs that we're thinking about what is a policy in place. So for example, for breast cancer screening. But when we get down to the individual level, there is so much heterogeneity in many situations, especially around prevention programs for preferences, both for the types of kind of screening or intervention, or for the types of outcomes that it is very hard to apply. So I think that's just something to keep in mind. We're talking about population level recommendations here. There are four standard types of economic evaluation: straightforward cost analysis, the cost effectiveness analysis, in which we're measuring costs in monetary units and we're measuring the health consequences in natural units such as influenza case averted, COVID case averted, cost utility analysis, you'll hear that used sometimes. That is really just a special case of cost effectiveness when we're translating all of the health outcomes into quality adjusted life years. And the metric there is dollars per quality adjusted life year gained. And you'll often hear those two terms used interchangeably, but they do technically have slightly different definitions. The fourth type is cost benefit analysis, which is not used very often in health, although we are starting to see it a little bit more often right now, but it is when the costs are measured in monetary units, and the health consequences are also translated into monetary units, typically using a metric called willingness to pay. The field it's very widely used in other types of policy evaluation, for example, evaluating environmental regulations. The application to health has moved away from that because there are distributional concerns with it translating everything into willingness to pay. You can imagine that if there's a condition that differentially affects a part of the population that has more resources, that would then affect the valuation of an intervention for that term. And so using quality adjusted life years is a strategy for kind of moving away from or avoiding those distributional concerns. Not that we don't have distributional concerns with qualities. We won't get into those today, but there's kind of a whole session we could do on kind of the limitations of quality adjusted life years. So just kind of one final note here that it is almost never appropriate to do only a cost analysis. So you will see in the literature analyses that do focus only on the cost. And as a consumer of the economic literature, what's important to ask for those types of analyses is whether there is a change in health outcomes that is not being measured or accounted for. So there are some applications where it would be appropriate to do straightforward cost analysis. For example, for influenza vaccination, if we're thinking about an activated vaccine that's being delivered in different settings, the physician office setting or a pharmacy setting or a drive-through clinic, that the effectiveness of that intervention will be exactly the same regardless of where it's delivered. And so therefore it is appropriate or would be appropriate to do a straight cost analysis or cost minimization analysis to understand kind of where is the most efficient setting for delivering that particular vaccine. However, if we were considering two different types of influenza vaccination, so an activated vaccine compared to live attenuated vaccine, which actually have different profiles of side effects and also have different levels of vaccine effectiveness, which actually vary by age, then it would no longer be appropriate to do a simple cost analysis because we wouldn't be accounting for the differential effectiveness between those two interventions. So that's something to keep an eye out for when you're reading literature. Okay.
You said this would be,
Sam? What?
I think this was like an hour and a half talk, but I guess in the public, like in the press, I saw that qualities were banned. Is that, and that's not a.
They have not been banned.
Okay.
So thanks for raising that question. So back in the original legislation for the Affordable Care Act, there is language within that legislation that prohibits the use of any ratio that is presented in terms of dollars for quality adjusted life years. And then it goes on to say, or a similar metric. At that point in time, there was a lot of concern that would essentially translate into a ban on quality adjusted life years. What I'll talk about in a couple of slides is that here in the United States, cost effectiveness analysis is not used broadly in any of our public decision making. And so there aren't many places where it could really be pulled back, but it is used explicitly in decision making by the ACIP. The ACIP and CDC was worried that there would be some restrictions there. Those didn't go into effect. More recently, there was some language that was passed by the House around quality adjusted life years. It has not been picked up by the Senate. We're keeping a close eye on that. It doesn't look like it's likely to move forward soon. So I think like every 10 years or so, we're kind of seeing this.
Sorry, and the argument against it is like
what gets quality adjusted life
Oh,
years.
Yeah,
So, we're not gonna have time to go into that today, but there are, essentially what we're doing is we're translating all morbidity and mortality into
Into
a
money.
single metric. No, into
okay, just
quality.
one,
Into a single metric. And so when we do that, there are questions around, I mean, one thing that I've focused on a lot in my research is how health utilities, which are used to derive qualities, differ for pediatric populations compared to adults. And, Kim presented some work on that last week as well, that we have a lot of evidence now that health utilities, are different for kids. I don't have to argue here to this group why we think they should be different, but that took a while for the economic field to kind of acknowledge and kind of move into that space. But there are also questions around potential discrimination against older populations, because if we're counting the number of qualities left, then we are by definition we'll be counting fewer qualities for your populations that are older compared to those that are younger if it's life-saving treatment. One might imagine that for kids that then they would benefit the most from the use of quality adjusted life years, but interestingly, they do not, because we also typically discount future costs and outcomes in cost effectiveness analyses. And so then with the discounting, anything that happens kind of beyond 30 to 40 years in life tends to make much less of a difference in terms of the overall ratios. And so actually qualities or applying cost effectiveness analysis to children, it doesn't necessarily address that limitation. So we kind of have issues on both ends of the lifespan. So that's just a couple of, there's many papers I can share on limitations of qualities. But I think at the end of the day, they provide one approach to comparing across many different types of interventions for many different populations. And I'll talk a little bit about how they're used in other countries. Okay, great. Thanks, Sam. So a second misconception is that all preventive programs result in cost savings. This is something that we've heard kind of periodically. Again, this kind of seems to come around regularly, that if only we invest in more preventive programs, we'll be able to yield all of these cost savings that we can then use to pay for expanded coverage or other types of health interventions. But when we look at the data, so this slide shows a sample of published cost effectiveness ratios from the Tufts Cost Effectiveness Registry, and the distribution of ratios in terms of dollars per quality adjusted life year. So in dark green are preventive programs, in light green are the treatment programs. All you need to see here is that the distributions look very similar. And so for both prevention and treatment, we have proportion of programs and interventions that are cost saving. Similarly, then we have a number that have cost effectiveness between under $250,000 per quality adjusted life year. And then we have a higher range that still looks very similar. And so, if again, as a consumer, if you hear somebody saying like, oh, if only we could invest in prevention and then we can do X, Y, Z, it really depends kind of what preventive program you're talking about. And so a couple of specific examples in the next slide, I'll show some incremental cost-effective ratios for vaccination programs. Another example from newborn screening is that even though the costs of screening are extraordinarily low for adding any new condition to the newborn screening panel, if they can be added to the standard panel, it is typically pennies for adding those. Once you account for kind of additional follow-up and diagnostic testing, maybe a few dollars for adding those screens, per baby. But when that is summed across the entire population of 3.65 newborns annually, and then identifying that very small subset of children with rare conditions, that does not yield a cost-saving program. So for example, here for MCAD, the cost effectiveness ratios is $21,000 per poly, which we would consider to be very cost effective, but not cost saving. So again, we're investing in the newborn screening program to identify kids, in this case, who have MCAD, who can be diagnosed and more importantly, treated earlier and can save the lives of those children. But again, it costs money at the population level. And so what we're asking again is which programs provide good value, which ones are providing a good return on investment for our public dollars.
So, sorry to ask the naive question. So for the example of newborn screen, you could argue it's not cost savings, but it's worth the investment because as a society, we put value on identifying the rare diseases and the
That's right.
health benefit. So it's a societal value rather than a quality value that you're getting out of it.
Right, exactly. And I think, just to step back even more broadly, I think like we can safely say that as a society, we place a value on health, that it's not sure where it is right now, 20, maybe 21% of our GDP is spent on healthcare. So, I mean, as a society, we're clearly investing in health and we find that important. So in terms of kind of how it's used here in the US, so just to comment on, again, there is a public resistance to using cost effectiveness analysis in public policy decision making. We rarely see it used for global coverage decisions. For example, will a vaccination program be recommended or not? But more often it is for identifying target populations within that recommendation. There are only a handful of examples of where CEA is used explicitly in public health recommendations, and that's with the ACIP. The Advisory Committee for Heart Disorders in Newborns and Children also uses cost effectiveness analysis where it's available for newborn screening decisions, but in a little bit of a different way than the ACIP. The ACIP has it as part of their charge, and so we'll always commission an economic analysis for any new recommendation. The acting is kind of will just use analyses if they exist, but they don't have the funding. It's not in their charge to explicitly commission a new analysis for every new condition that they're evaluating. There is a not-for-profit organization called the Institute for Clinical and Economic Review that is funded by essentially all of the large health plans in the US. And they provide typically for more expensive therapies. So for example, the gene therapies, they've done both clinical and economic reviews of all of the gene therapies as they've been rolled out over the past few years. And those data are presented, they have a very public process. What we don't know is exactly how that information is used. It's clearly being used by the health plans. They pay for it like, through this nonprofit organization. But as we know here that many of the decisions about kind of how healthcare is financed, especially around specific interventions, is not seen to us directly, in private care. So a couple of points about the challenges to widespread use here. So again, kind of different from if we think about Canada, the UK, many European countries that have a national health system, where those decisions are being made globally at the national level. And importantly, there is, especially for pharmaceuticals, negotiation, at the health system level for prescription drug prices. We have here a very fragmented healthcare system. The only part of our health system that looks anything like a national health system is CMS. So Medicare, though, is prohibited by its authorizing legislation back in the early 1960s from using cost in any of its coverage decisions. So that is essentially a ban, like more than anything we see cropping up here and there about qualities, that we don't see going away anytime soon. And so that's kind of a huge portion of our public health budget that cannot be informed directly by cost effectiveness analysis. We have both political resistance, as we talked about earlier, cultural attitudes and expectations just as a population. Like we are very resistant to thinking about rationing healthcare, although by not, what I would argue and United Health Economists would argue is that by not doing it explicitly, we're then implicitly rationing by not providing coverage to a whole swath of our population. And again, there is methodological complexity around, is there sufficient expertise to conduct evaluations? And we talked a little bit about limitations of qualities, but again, like those are able to be overcome, and there are many countries that do use cost effectiveness analysis in their population level decision making. But again, to highlight that similar to how they're used in the ACIP, that kind of cost effectiveness analyses are never used as the single decision criterion. They're one of many inputs as to whether a new intervention, a new drug, a new gene therapy, will be covered, by health. Jeremy.
Yeah, thank you. I'm curious about this organization that does the analyses, the Institute for Clinical Economic Review. I mean, so, and my question is actually about the timeline that they look at. So, like when we're thinking about CMS or federal policy or coverage like that, there's a long timeline. You talked about not evaluating more than 30 years out, but health policies have usually it seems to me, a very short window that they look at because people change policies so much. Do they actually look at any long-term outcomes at all in these analyses?
That's a great question, and we don't know, right? Because the average length of time in any health plan is, I haven't looked at these data in a while, but it's really short. It's like 3 years or something. And so, maybe they're taking that short-term view, but then at the same time, people are moving plans, they're going somewhere else. So someone's gonna be coming from that plan over to your plan. So we don't know that they're necessarily taking that short-term view. It's possible.
I have a question. On last meeting, you were talking about the cultural attitudes and expectations. You said that like in the US, the attitude or typically people are against rationing healthcare. And I don't know if you could explain that a little bit more, because I feel like I see the opposite, like when it comes to like opposition around new programs or adding additional treatment options for different diseases.
Say a little bit more about that.
I'm thinking specifically when it comes to sickle cell and just like the pushback when it comes to like coverage for more hematology visits or things like, that's what, and when you say like rationing over, it seems like if our society is opposed to rationing, that it would be more open to providing more treatment options so that people are able to access help more, or is that not what you were saying?
No, so I think, well, I think that the resistance to sickle cell options, falls into a different category. That there's clearly emerging evidence in those of you that are working the field that, there is also bias towards many vulnerable populations. And I think that's likely what's playing out in terms of sickle cell, access to sickle cell interventions. But what I was referring to is that if we were to look at other health systems that systematically review interventions and look at and kind of make explicit decisions about at the population level who will be getting which treatments, so that there is kind of less coverage for the entire population, fewer resources available, but everyone is covered, that is not a value that we see in this country. I will say, over the past 20 years, that perception seems to be changing a little bit. That when, I first started out as a student in health policy, I don't think at that point we ever thought that we would see, a national health program being really seriously considered, in our country. And that's essentially what Medicare for All is. And I think it's a brilliant branding of a national health system. And so I do feel encouraged that there's been some movement. I don't know that we'll see it. So, but I remain hopeful. Any other questions about this before I move on to the COVID example? So this is just an example for vaccine policy, so the Advisory Committee for Immunization Practices since the 1980s has included economics as part of its formal evidence review. So what I'll be presenting in the second half of this talk is the work that we've been doing in collaboration with the CDC to support decision-making and recommendations around the COVID-19 booster vaccine program. So, and before we go into that, I'll just highlight, these are a few cost-effectiveness ratios from that are recommended vaccine programs throughout the years. And the top half of the table are some of the older vaccines that have been around for a long time. In terms of cost per dose are very inexpensive. And so we do see for our older vaccines that they tended to be cost saving. Newer vaccines tend to be at a very different price point and are often cost at $200 to $300 per dose. And what we're seeing, are variable cost effectiveness ratios, often varying with the target population. You can see for the COVID-19 booster vaccine program, and this is the analysis that I'll go through in more detail in a little bit, that for the different age groups that the ratios are most favorable for older individuals. So individuals 65 and older vaccination is cost saving. For the two younger age groups, there's an investment required for an improvement in health. You can see that there are some ratios that are, higher, close to $300,000 per quality. The question is kind of where do we draw that line and what is the ratio? Here in the US, we don't have a specific threshold, and the CDC will never state that they have an explicit threshold. They have an implicit threshold that is roughly between $100,000 to $150,000 per quality. But again, when we think about the context of how these decisions are made, the economic evaluation is not the single criterion that they're using. They're looking at a broad body of evidence, and for various reasons, it may make sense to invest in a program that is slightly less efficient. In other words, that has a higher incremental cost effectiveness ratio. So you had a question, Erin? Yeah.
Oh, I was gonna ask kind of what you were alluding to, of like, what is considered what is it considered a good ratio versus not?
Great.
So, yeah.
And
Are there other countries that have explicit,
Yeah.
what is, who and what?
Yeah. So that's a great question. So the UK in their national health system has the most kind of explicit and closely adhered to thresholds. I don't know what it is right now, but it is much lower than ours. Last time I checked, it was around 30,000 pounds per quality, which is just under $50,000 per quality adjusted life year gained. But in the last few years, they have added some exceptions to that, which reflect kind of the societal preferences both there, and we see the same thing here for kind of rare conditions in children. And so they have an exception that if an intervention meets a number of different criteria, so it has to save a certain number of qualities at the individual level, 30 plus, which essentially means it has to be a life-saving treatment for children, and life-saving, not just, improves their quality of life. And it has to meet some other conditions. And then those treatments, have a much higher threshold. So even higher than, our 100 to 150 here, probably similar to like $250,000 to $300,000 per quality. Sure.
So sort of a nuanced question, sort of related to Sarah's and sort of related to Melinda's. So you talked about like using these metrics to make population level decisions, but clearly you're looking at subsets of the population here. Or when you talk about the UK, there's a carve out for a particular population, right? And I was thinking about Erin, right? Like if you think about these metrics amongst the kids who land in an ICU, the number is really different than if the denominator is like all kids out there or all adults or something. If you're blending in adult ICU care with kid ICU care, right? Like very different problems, different. So like how narrow or wide does the population have to be in order for this to be a reasonable approach?
So thank you for asking that perfect question for what we'll go through in a few moments. So the key thing, again, thinking about, cost effectiveness analysis as a consumer or as a user is that in order to, so even if we're talking about population level recommendations, that it may be and is often essential that that target population be stratified into different subpopulations. And typically, most importantly, to reflect either differences in underlying rates of illness. And so here for, or differential effectiveness of the intervention by subgroup. Those are kind of the two main rationales for stratifying subgroups. And so here for COVID-19 booster, we've stratified into these different groups, primarily due to hospitalization rates and using that as a proxy for the burden of the condition on different ages. What we haven't included, and I'll talk about that a little bit more, for COVID-19 is risk status. And, that's where, there could be different recommendations within an age group for those that are at high risk for COVID-related complications compared to those that are not. That's where, with COVID-19 being such a new illness, we don't have like years and years of data. We have a few years of data, but we don't have good definitions yet for who's at high risk or not for complications. And so that's something that, we've been working with CDC on. So for example, for influenza, like CDC has a very specific list of conditions that they include for their definition of who's at high risk for complications from illness. And they do not have that developed yet for COVID-19. It's really interesting. So again, just to summarize, thinking about from the consumer perspective, cost effectiveness does not equal cost saving. So if you hear that, you can perk up and really think critically about what is being presented either in that paper or that presentation. And similarly, that prevention programs are not necessarily cost saving. Some of them will be, but some treatments will be as well. And it's important to keep that in mind. And again, here in the US and also in many other countries, that cost effectiveness is used as an aid to decision making, an approach to evidence synthesis. We'll talk about uncertainty analyses in this specific worked example. Often when we pull together all of the data and information that's available to model cost effectiveness, that if the underlying strength of the evidence base is apparent in the robustness of our estimates for the cost effectiveness ratios. And so just further highlighting that the sensitivity analyses and scenario analyses are of key importance. So if you're only seeing the mean cost effectiveness ratios, then the next question to ask is like, how sensitive are those, is that result to changes in the underlying parameter inputs? And there has been an increasing interest in cost effectiveness evidence, despite what we see happening from, our legislators from time to time.
Lisa, I have an overall question about cost effectiveness analysis. I feel like in all of our fields, there's different things where we're like, every time we see a paper on it, only like 10% of the papers are doing this correctly. Is that what, how, when we see cost things in the literature, are these things where we should be just really hesitant most of the time?
Yes.
Okay.
The short answer. Okay. Yes, and I will say even for some of our top tier clinical journals, and so they may not have health economics reviewers that they use. Their reviews can be uncertain. I recently got back a review from JAMA Network Open on cost effective analysis. That was one of the worst reviews. Not that it was a scathing review, it was like the poorest review, like the reviewers were not qualified that I have seen, maybe in my whole career. I was disappointed. I wrote the editor. I'm not sure if that helps,
That's
but,
impressive.
but
That's impressive. The worst in your career.
it was shocking. I mean, I did write the editor because, I mean, that shouldn't be happening at our top tier
Right.
journals. But I do think that if you're reading an economic analysis in a clinical journal, yes, that it's important to really scrutinize, what is being presented in that paper.
Sure.
Yeah. As opposed to if you're reading it in, a health policy or health economics journal,
Yeah.
where it's likely that you'll have gone through rigorous review process.
Sure.
Okay, so I'm gonna run through the analysis that we presented to the ACIP in September of 2023 for the COVID-19 booster program for this vaccination season. This is the first phase of the analysis. We presented a second phase of the analysis at the February ACIP meeting that evaluated an additional dose of COVID-19 vaccine for older individuals. And then we'll be presenting our phase 3 analysis again. I'll end by showing how quickly the evidence base is moving for COVID. In June, we'll be presenting an analysis forecasting for next year's 24-25 vaccination season. And we'll be adding pediatric age groups into that evaluation. We're in the process of doing that right now. And go ahead.
Finish your sentence.
No, go ahead.
I was just gonna say, you said vaccination season, which is not how I've been thinking about COVID-19 vaccines, but is that how ACIP is thinking about it now?
They are. Mhm. They
I mean, which
really-
is what we predicted, but I just,
Yeah.
you're the first person to hint that that is actually how it's being approached.
It is, yes, and I'm not sure how much let's save some time to talk about, because that is really interesting, because it's not clear that we have seasonality in, in looking at kind of the seasonal, epidemic illness curves. And so it is interesting, but from a policy perspective, like you have to do something, right? So it will be interesting to see how this plays out. So in this analysis, we are, as with any standard cost effectiveness analysis, we're estimating, in this case, the annual disease burden, again, back to your point that we are now looking at an annual vaccination season. And modeling healthcare utilization associated with COVID illness and with vaccination, including cases of symptomatic illness, hospitalizations, deaths, adverse events, costs, and quality adjusted life years. And the two strategies that we're modeling is an updated mRNA booster against COVID-19 associated illness in persons aged 18 years and older, compared to no updated mRNA booster. And I'll just pause for a moment and talk a little bit more about our comparison intervention. And so again, when reading cost effectiveness analyses, again, to think about the target population, but then to also consider have all of the key intervention strategies be included in the analysis, because the cost effectiveness ratios are incremental cost effectiveness ratios. We're comparing them to something else. And if the appropriate comparator is not included in the analysis, then the incremental ratio will be incorrect. So here we are comparing against no updated mRNA booster. We have received from many people within the CDC work group, the ACIP, random people that email me when they see that we're presenting to the ACIP. Why aren't you stratifying the comparison groups to, either those that have received the full vaccination series, 2 doses, or, the full series and a booster and are now getting another booster, as well as those that have not been vaccinated. And the reason we have not done that is because is actually for 2 reasons. One is that at this point, far more than 90% of the population have either been vaccinated, had COVID 1 or more times, or both. And so kind of there is now kind of this underlying immunity among the population that we need to take as the baseline. And so when we look at these ratios, when we look at vaccine effectiveness, it looks nothing like it did for the original COVID vaccines, because what is being prevented now is very different than when we had a naive population and we were preventing initial infection. So that's why we haven't done that. The second reason is that the current boosters effectiveness tends to wane very quickly. Most of the effectiveness has waned, and we'll go through this in a minute, by 6 months or so, although there is some kind of lingering effectiveness after that point. But so back to your point, Toby, that why is CDC thinking about an annual vaccination? Partly it's because the effectiveness of the vaccine tends to be waning so quickly. And so that's why a second dose is being considered for 65 and older, and was actually recommended in February at roughly the 6 month mark. But does it need to be the fall and then spring? No, it could be whenever the initial dose was, and then maybe 6 months after that. We've stratified by the target population. I talked a little bit about the fact that we don't yet have sufficient data to stratify for high risk and non-high risk, but we've conducted a number of sensitivity analyses to look at kind of what might proxy for a high risk population to get a sense of what those ratios might look like. This will not be a surprise to anybody in this audience, but the evidence base for pediatric and adolescent age groups is much less robust for COVID, both for vaccine effectiveness as well as information on kind of the effects of the illness, and except for hospitalization rates, which we have good data from COVID-19, but other than that, we have a really scarce evidence base here. And so in the initial phase of the modeling, we actually tried to include the pediatric age groups, and we actually dropped them in August of 2023, and in consultation with CDC, and just said what we're modeling right now, the ratios were just so wide, anywhere from cost saving up to $1 million per quality. And I said, this information will not be helpful to the ACIP. I said, we're going to leave them out for now, and we'll do additional work and we'll bring this back for a future analysis. So we're now doing some additional work to add those pediatric age groups. This will be a really interesting policy discussion. Again, what we're looking at now, and again, I think it's probably not a surprise to this group, that we don't think that that the cost effectiveness ratios are likely to look favorable for pediatric age groups. And what will the CDC do with that? Where will the recommendations go? Will they consider kind of a risk stratified recommendation, for children that are at high risk for complications of behavior? That's how we're hoping for.
And any of these, and this might be a very, very different question. Ignore me if this is not, but it just occurred to me. Sorry, as an epidemiologist who's an individual level story, but I know it doesn't jive with, but I have one kid that's high risk, but not the other. And how are there ever recommendations that think about vaccinating at the family unit or the household unit more so than the individual unit?
Well, so typically those high risk recommendations will include persons who are close to somebody who's high
Okay.
risk. So
Okay.
yes,
I don't know if I knew that.
yeah. So I'm just going to run through kind of some of the details of the model, but I'm not going to get into the guts of the model because I want to talk about the results. But just to share that what we're using here is a decision analytic model. So we're simulating what happens over the course of a year, because that's the time horizon where we anticipate there will be another vaccination happening in a future year, just like influenza. Although our intervention time horizon is 1 year, we do account for any costs or qualities that accrue beyond that time frame. So for example, if somebody dies, that's included in the model.
Maybe you're gonna get to this, but
Yeah.
if there's not, if the vaccine effectiveness wanes in 6 months and there isn't a clear seasonality to this, why use 1 year as the
Mhm.
unit?
So I'll hold that thought just for a moment. But so this slide shows a simplified version of our model schematic. What's important to know here is that every arrow, every branch in this model represents a transition probability. And each of these health states is associated with both a cost as well as a loss in quality adjusted life years. And so as we run populations through the model, we count up all those costs and qualities and then compare what happens in the booster vaccination arm compared to the no booster arm. I'm happy to take questions on the model, but we don't need to get into the guts of this at all. Yeah.
There's no societal like work loss or things like that that's.
Yeah, it's all in there.
It is,
Yeah, it
okay.
is. Mhm, yeah. And I'll just, so let me go through it. So our analysis plan, again, we're calculating incremental cost effectiveness ratios. And then I cannot highlight enough that kind of the results of cost effectiveness analysis are not just the base case results, but the base case results and the uncertainty analyses. What happens when you vary all of these various inputs that we're feeding into the model? Because there is a level of uncertainty associated with all of those. We don't have perfect information. And especially when we think about seasonality. And so, are these results robust to changes in those underlying?
And as part of that uncertainty, these evolving strains that like maybe they might be worse or more
Mhm.
aggressive or less aggressive.
Yeah, and that's it. And that is to some extent reflected in the uncertainty around. So this is probably a symptomatic question. I'll just say here, like, we have terrible data on this parameter. And so this is like an assumption in the model. We've actually essentially divorced this parameter from our other parameters in the model. So for many conditions like influenza, like we would have hospitalization conditional on experiencing infection. We have actually separated those within the model. So these vary separately. We can vary them together, but our hospitalization data is so much more reliable than these data. And so these have some impact, but it's really the hospitalizations and the other complications that drive the cost effectiveness ratios. So this slide shows the hospitalization rates. And so here, Jeremy, CHEAR question is there's a low and a high range that reflects to some extent kind of what's happening with, with the epidemic throughout the year. So vaccine effectiveness, I'm not going to talk about this too much, but just to say that we don't have great data on the effectiveness of the COVID boosters. And so we're using data, that 6-month data, we're then extrapolating. We've got a bunch of scenarios that we include in the model, either an optimistic scenario that after 6 months that the vaccine remains at that level of effectiveness, a conservative scenario where it drops to 0 after 6 months. And then our base case scenario is where there's linear waning until the end of the year. Again, we vary these beyond kind of what we're seeing here as well. And so, that's the approach that we take. So it's that whole area under the curve that we use to proxy for an annual vaccine effectiveness. In our phase 2 analysis that I'm not presenting here today, we've actually imposed an epidemic curve on top of this. And so we have these seasonality adjusted vaccine impacts. And that's where the vaccine effectiveness will differ. If we've got a peak in illness, in February compared to November, relative to the vaccination timeframe. And so we are including that in the model. Yeah.
I'm sorry if you said this, but there's obviously different COVID vaccines. How do you think about that in this? Is it all kind of averaged together?
So we're modeling a generic, thanks for asking that question, a generic mRNA vaccine. And they
Okay.
actually look pretty similar.
Okay.
And even Novavax, so their booster was not available at the fall ACIP meeting, but their effectiveness looks pretty similar too. They might, their vaccine might have a little bit more durability beyond the 6 months, but they all look pretty similar.
Okay.
I have a question.
Yeah.
I just want to make sure, so the y-axis is saying, these are the percent of people who got the vaccine who did not have a hospitalization, right?
That's right.
So only 61% of those did not.
Right, so it's 60% effective, like right after you get the booster, and then it drops to, what is it, like 50%? We've got two different studies here that we're then combining. So then it drops to about 50% from in the third and fourth month, and then it drops down to like a little over 20% in the fifth and sixth month. So
And that's just, again, just reflecting like the people that
that's
got
the
the
VE,
vaccine.
the vaccine effectiveness
Oh, okay,
in preventing hospitalization.
okay.
So not everybody who gets COVID gets hospitalized. There's some rate of hospitalization. So this is the improvement in the rate. It's
Okay.
not an individual's risk of
Okay.
being hospitalized.
Okay.
So this slide just shows the summary across different endpoints in the model. We've actually stratified this by age in the phase 2 model, and we'll be adding the pediatric groups for the phase 3 model. And then to your question, Joe, so this slide just lists kind of all of the other inputs in the model. So we include direct medical costs, we've included productivity losses, vaccination costs, importantly include not just the cost of the vaccine dose, but cost of administration, as well as time costs for getting vaccinated, as well as all of the both direct costs, productivity losses, and qualities associated with any vaccination-related adverse events. So those are all included there. Yeah, go ahead.
So for the inputs into the model, I mean, the ACIP and CDC make recommendations that like people with asthma, immune suppressed populations, they do subdivide by groups. Is that in future analyses to come, not yet in this set?
That's
This
right.
is just a population as a whole.
Stratified by age only, yeah.
Thanks.
So the only thing I want to highlight, I'm not going to go through any of these in detail, but just to say that every single parameter that goes into the model has a range. And that is often parameterized using a distribution so that we can create essentially a quasi-confidence interval for the ratio. So again, I'm not going to go through these in detail. Again, this is just a highlight here. Just going to highlight here for a moment the cost per dose. So the prior to fall of this year, the cost of the vaccine dose was still covered under all the government contracts that had been entered into during the height of the pandemic. And that this fall was when all of those expired. And so this is actually a little bit low. So this was our best information, in September of 2023. They're actually pricing them even a little bit higher at $125 to $130 per dose, which is, we can talk about that another day, but it is just, it is disappointing, I'll say, to see where a situation where industry had essentially all of their R&D costs covered for developing these vaccines, have recouped many profits during the initial years of the pandemic, and have now raised these prices to the point where vaccination is likely not cost effective for some of these subgroups. I'm not going to go through these in detail. This slide shows our disaggregated results. I just want to highlight these for a moment because these are often quite important to policy decision makers who may have less familiarity with cost effectiveness analyses, and important to be able to demonstrate if the results of a simulation model in terms of the health outcomes, as well as in terms of the economic outcomes. So this slide just shows comparing the booster dose to no booster in terms of number of cases. And so on the left-hand panel, compared to cases averted with vaccination. And so in the column, but in the column under cases averted for cases, so those are all types of cases. You can see those are fairly similar across the age groups, but where we see differences is for hospitalizations, hospitalizations that require ICU care, and for deaths, that those averted cases increase substantially with age.
So how is population size worked into these?
So we're not modeling here coverage, and so we're really looking at, so this is a cohort of 100,000
Okay.
vaccinated compared to 100,000
Okay.
unvaccinated, yes.
But do you do the math to say in the US population, there are umpty million people over
Yeah, we often do that.
65,
Yeah, we
so,
often do
yeah.
that, and we're not presenting that here, but yes, it's a great point. But then that's where we have to think about the coverage, because we can't assume that everybody's gonna be vaccinated. So then we typically look at that.
So like a penetration into the population.
Yeah, yep. So,
I had a question online too, whenever you have.
sure, David?
Thanks. The slide that you showed previously, the cost of the vaccine itself.
Yeah.
And you were disappointed with pharma's sort of upcharging, considering the population that are eligible. My question is this, that your research is aimed at informing policy, right? So that proper investments, at least our knowledge of what yields value and what doesn't. I understand that, even though you're saying that lots of assumptions built on assumptions. But what about the other side of policy, that we allow pharma to set any price they want? That is also policy. So I'm wondering, as a big picture, because I don't know the science of this field, but at a 30,000 foot level, how do we merge these two things? Because ultimately you want to inform the government about what is value, and yet the government also does things that are unquestioned that totally mess with budgets of, here, you said we're paying like 19%, 20% of our GDP. It's never gone down, it only goes up. I've asked Gary Feed repeatedly, is this sustainable? He says, sure, why not? It could be 50%. It could be 60%. So can you comment on, is anybody trying to balance this?
Well, so I think we've seen the Biden administration actually put into effect some new legislation that will actually allow for a direct negotiation with drug companies for certain prescription medications, which is really exciting to see. Are we likely to see that more broadly in this country without having a national health system and a strategy to do that more broadly? I can't answer that question. That's far beyond the scope of this presentation, but I agree with you that we are losing out in terms of not being able to have those direct conversations and be able to negotiate direct with drug companies. And so I do want to finish up, but I'm happy to talk more about that at any time. So in the last minute, I will just say that these are the ratios for 3 age groups that we looked at. So the youngest age group, 18 to 49, it's kind of on the border of what we would consider to be cost effective. But we do see, move it forward again, might have just here. Great, thanks. That if we look at kind of which parameters are most influential, this slide is a tornado diagram that shows, how important cost is in terms of driving those cost effectiveness ratios. But here we're proxying for a high-risk subgroup by modeling higher rates of hospitalization. And here we can see that for high risk within that younger age group, 18 to 49, that for any conditions that are associated with kind of 2 times the base case hospitalization rate, We have a list of those that we've incorporated into our phase 2 analysis, that those are much more cost effective, really fall within the benchmark. And so here, it would really be advantageous to be able to do a risk stratified analysis, and we hope to be able to do that later. I will just say that in terms of robustness of our results, that for the 2 older age groups, those cost effectiveness ratios are very robust to changes across the parameter inputs. Not so much for the younger age group, very sensitive to changes in the parameter inputs. And again, highlighting that if a risk stratified analysis would really be the right thing to do here. Next steps, we're integrating pediatric age groups. We are looking at seasonality adjusted vaccine impact. We're updating the hospitalization rates, and I'll just leave you with this recent snapshot from the COVIDnet data, which shows the weekly rates of COVID-19 associated hospitalizations by season. And that the green line is the 2022-2023 data that we currently have in the model. So for 2023-2024, you can see in the red line that looking at the October through January data, that is already substantially lower than what we saw for the previous season. And so we'll be incorporating that into our next phase of the model. But then, of course, like to the points in the conversation before, like we don't know what's likely to happen in February, March. Like, will we see a peak in the same part of the year that we did in previous seasons? We just don't know. And so we'll be modeling a number of different scenarios in collaboration with CDC. So I'm at 10:01. I'm going to stop there, but I'm happy to stick around and answer any other questions. And nice to see everyone who's online.
Thank you. It's so cool to like